Hi everyone, I'm Dr. Parissis. I work in London, UK, in partnership with Feller and Bloxham Medical in Great Neck, New York. And what I want to do today is go through my research paper with Dr. Bloxham that I've been working on for the last year. And the idea for this research paper came when me and Dr. Bloxham were discussing what approach might be best to get the most number of grafts from a patient over a lifetime. And we narrowed it down to two approaches. The first one being FUT and then later doing FUE, and the second one being just doing FUE alone. And the main question being which approach gives more grafts over a lifetime. You can see here just a snippet of our paper which we are hoping to publish into the International Society of Hair Restoration Surgery. Just a reminder of the aim of the study, which is to assess which approach gives the most number of grafts over a lifetime, and how we're going to do this, i.e. the method, is through looking at past research of hair restoration surgeons, taking values from their papers and using it to make our own results. So just some background. There are a number of factors that affect the cosmetic outcome of a hair transplant, and the first one being the number of transplanted follicular units. Obviously, if you transplant 2 follicular units, that's not going to look as good as 2,000 follicular units. Hair characteristics are also very important, specifically the number of hairs that each follicle contains, or each follicular unit contains. They vary, so some of them are singles, they contain 1 hair, some of them are doubles, they contain 2, and some are multis, which contain 3 or more hairs per follicular unit. The diameter of the hair shaft is important. Coarser hair, i.e. wider diameter hair, is going to provide more coverage. The difference between the hair and the scalp color is going to determine a more or less natural appearance to the hair transplant. And straight versus wavy, or might I add curly hair. Wavy or curly hair is going to give more coverage versus straight hair. The other two factors are strategic placement of the follicular units into different regions of the scalp. So hair transplant surgeons tend to put more follicular units in the hairline because this is a more cosmetically important part of the hair transplant outcome. And the exit angle of the hair. I've seen lots of hair transplants go wrong because of the inappropriate exit angle of the hair. It's important to produce a very natural appearance. It's important to get it right. The reason why I've highlighted the number of transplanted follicular units is because arguably this is the most important factor which affects the cosmetic outcome. Just an overview of male pattern baldness, a little bit more in the background. It is also called androgenic alopecia, but it is the most common type of hair loss that we see. And it's described as shooting at a moving target. And that's because it progresses and the hair transplant aims to catch up with it. So, the patient might lose some hair and then we might replenish it with a hair transplant, but it will progress and then we replenish. And there's kind of that endless cycle. With someone with advanced hair loss or someone who's predisposed to lose all their hair, it really is shooting at a moving target. And of course, someone with advanced hair loss is going to want the most number of follicular units over a lifetime. And just a reminder of the question that we're asking, we're comparing these two approaches, FUT and later FUE, versus just doing FUE alone. To compare those two approaches, there's a number of variables that need to be considered. These include the scalp laxity of the scalp, the safe donor area, the follicular unit density, the excision percentage of FUE, the strip length of FUT, the survival of the grafts from the hair transplant process, and then the transection rate during the hair transplant process. And for each of these variables, we looked at different papers and sort of obtained values that we then used to make our own results. The first variable we mentioned is scalp laxity, and this refers to how much the scalp tissues can stretch when they're placed under tension. We looked at 2 specific papers on scalp laxity. The one on the left is by Pathmanovich et al., and they used cross-beam laser measurements and basically found a difference between the scalp laxity at the back in the occipital region versus in the parietal regions, i.e. on the sides and the lateral sides of the head. They found that the scalp laxity was more in the occipital region than the lateral regions, which lines up with what I've seen in hair transplant surgery. That's why we tend to go a little bit more narrow on the sides so that closure is a bit better. The second paper is the one you can see on the right here, which is by Dr. Park. He used a laxometer 2 device to measure the scalp laxity of 88 different patients and found the average scalp laxity to be 21.31 millimeters. So really what we've done, so our scalp laxity value, is using an average of the 2 papers. So we've taken the 19.5 millimeters, which was the scalp laxity of the occipital region of Pathmanovich's study, i.e. the first study on the left here. We've taken 15.7 millimeters, which is the lateral side, the parietal regions of the scalp. And then we've also taken Dr. Park's more generalized 21.31 millimeters, and that gives us 18.4 millimeters as an average, which 18.4 millimeters is 1.84 centimeters. The reason why scalp laxity is really important is because 1.84 centimeters will be our width. We're not going to go beyond 1.84 centimeters, because if you do, then there'll be problems with closing the wound. We don't want that. And of course, the width of the wound or of the strip is very important, because the wider the strip, the more grafts, of course, we're going to take with it. Second variable is the safe donor area. The safe donor area is the area of the scalp which contains follicular units that are permanent, or most likely to be permanent. A number of figures in the hair transplant industry have tried to pinpoint or define the exact surface area of the safe donor area. Some notable figures include Dr. Cole, who's been in the industry for many years. He stated that the safe donor area was 203 centimeters squared, but didn't take into account that there's differences in the surface area of the safe donor area between people, because people have different sized heads. You also have Dr. Robert Bernstein, he is a clinical professor of dermatology at Columbia University, and he said that the safe donor area is roughly 25% of the total scalp surface area. But doesn't give us an exact value again. You also have Dr. Unger, who was a clinical professor of dermatology at Mount Sinai Hospital. He conducted a very interesting paper, you can see on the left here, where he asked 34 highly experienced surgeons with a combined experience of 900 years in hair transplant surgery. He asked them to estimate the number of follicular units containing permanent hair in a 30-year-old patient, a hypothetical 30-year-old patient with type 5 or type 6 male pattern baldness. And he asked them how many follicular units might be in that patient with below average density, and above average density. As you can see here from this graph, the patient with the hypothetical patient with type 6 male pattern baldness, which is more severe, is of course in each density category is going to have fewer follicular units. And you can see the same here. This is less than this, this is less than this, this is less than this. Notably, however, I want you to take note of the patient here with who's a 30-year-old patient with type 5 male pattern baldness with average density. So this is, your average Joe, your average patient who comes in. Average patient is going to have average density. So just to highlight, 6,404 follicular units is really the result of 34 highly trained hair transplant surgeons. That's how many follicular units they believe are actually permanent for life in the safe donor area to use for transplant surgery. Here's a reminder of the Norwood-Hamilton classification of male pattern baldness. And I want you to take note of this patient here with type 5 male pattern baldness. If there's a 30-year-old patient with type 5 male pattern baldness, he has advanced hair loss. He's likely to progress to the sort of type 6, type 7 in the near future. This patient's going to require the most number of grafts over a lifetime. That is undeniable. And this is the patient that we're focusing on. This is the patient we're trying to help. Follicular unit density is another variable that we focused on, and this is of course the number of follicular units per unit area, follicular units per centimeter squared. This patient has less density, this patient has more density. These two papers both use microscopic photography to count the number of follicular units per centimeter squared. This paper on the left here found 65 to 85 follicular units per centimeter squared in 50 patients. This paper here found a follicular unit density of 78.2 follicular units per centimeter squared in 580 Indian men specifically. So we've combined the two results essentially. So we've got that 65 to 85 follicular units per centimeter squared, that's 78.2, and we've put them together, we've taken an average, and we have found the follicular unit density to be 76.6 follicular units per centimeter squared. That is what we are going to be using for the purposes of our study. FUE excision density is another important variable. So this is the number of follicular units per unit area per centimeter squared that we remove from the safe donor area by the FUE technique. This paper by Dr. Keane was one of the most in-depth papers on the excision density in FUE, and she basically used man-made density charts to conclude three main things. She found that leaving behind a donor density of greater than 50 follicular units per centimeter squared is likely to provide enough cosmetic coverage. 40 to 50 might produce a thin appearance, but it depends on the hair characteristics. Coarser hair, a lower contrast, hair to scalp color contrast, those things are going to affect the appearance of the safe donor area between 40 to 50 follicular units per centimeter squared. Less than 40 is likely to produce a thin appearance. That's what they found. So if we take our follicular unit density, remember that we found our follicular unit density to be 76.6. So if we take that, for instance, okay, we take a patient with 76.6 follicular units per centimeter squared. Dr. Keen's logic, we can remove 26.6 follicular units per centimeter squared to leave behind greater than 50 follicular units per centimeter squared in the safe donor area. And that's in line with point 1 here. That allows enough cosmetic coverage. Okay. Now, any additional excision is going to depend on the hair characteristics, as we mentioned. So because a density of 40 to 50 follicular units can produce a thin appearance of the safe donor area, we as the authors will assume that moderately favourable hair characteristics, so average hair characteristics, will allow for somewhere halfway between that range of 40 to 50. So we're say 45, okay? And that gives an additional 5 follicular units per centimetre squared, and that provides a total excision density of the initial 26.6, which we can safely take here. 31.6 out of 76.6 is 41% of the total follicular unit density in the safe donor area that we can safely remove by FUE in a patient with moderately favourable hair characteristics and average hair density in the safe donor area. And that's before risking a thin appearance of the safe donor area. That's the most important thing. Another variable is the length of the strip during the FUT procedure. With regards to strip length, there hasn't been a paper that has outlined the exact optimal strip length, but we've just used papers that have used strip length in their, whatever they've been looking at. So in the paper on the left, you can see by Dr. Tsilusani, he stated in that paper a strip length of 25 to 30 centimeters. The paper on the right, he also stated 30 to 35 centimeters. Both of these two papers stated a strip length of 30 centimeters. So because the overlapping common value in all the papers is 30 centimeters, we're going to go with 30 centimeters as a strip length, which really does align with Dr. Bloxham's experience. Most of his patients, he takes a strip length of about 30 centimeters, so that works well. In terms of graft survival, of course, that's the number of grafts that survive the hair transplantation process. Here you can see an image that I've taken. I took that myself. It is of a patient's grafts during an FUT procedure, and I just wanted to highlight just how healthy those grafts look. I mean, those are exactly what you want your grafts to look like just before you put those in back into the recipient site. There are a number of factors which affect the graft survival and growth yield of the grafts, if you like, and therefore the overall cosmetic outcome. And these include adequate hydration of the grafts, which Dr. Bloxham does very well with saline, constantly hydrating them with saline. The temperature of the grafts not being too much or too little, although more research is needed on that. Minimizing the time of the grafts spend outside of the body, ensuring that the grafts are handled with care, and also proper hair care post-operatively as well. In terms of the graft survival of FUT versus FUE, there's been a few studies, but none of them, there hasn't been too much. You can see the paper on the left by Dr. Shapiro. It did a side-by-side study of 3 patients who underwent FUT and FUE, and found actually that 54% of the grafts grew after FUE and about 85% grew after the FUT in the same patients. The paper on the left found that FUT and FUE was roughly the same in terms of graft yield. So as a result of this conflicting results and conflicting research, and also the fact mainly that there's limited research really, we're not going to take into account graft survival. Okay, we're just going to assume that it's the same for both approaches that we're taking. Transection rate is another variable, and this is the number of grafts or percentage of grafts that are harmed essentially by the harvesting process. There's a nice photo here you can see of a normal hair follicle. That's what you want the hair follicles to look like after the harvesting process. This is a partially transected follicle, and this is totally transected here. And it really is determined by the experience and expertise of the surgeon. This is the number one thing that patients need to know. It really is determined by that, and that's why it's so important to go with a surgeon who has very good expertise and who's been trained very well. But because it's so subjective and very difficult to measure, and there's very limited research on it, we're not going to take it into account. So what about our results? Now I want you to consider a 30-year-old patient with type 5 male pattern baldness, and I want you to consider that he undergoes an initial FUT and then he has another FUE. Now in that initial FUT, the strip width is 1.84 centimeters because that's the average scalp laxity that we found, and that allows us to take 1.84 centimeters width of strip. 30 centimeters of strip, as we discussed. You multiply this by this, you get the total surface area of the strip that we can take, which is 55.2. We said 76.6 is the average follicular unit density we're going to use, and we can calculate the number of follicular units that harvests by multiplying this by this. We get 4,228 follicular units by that initial FUT procedure. The same patient then has an FUE procedure. We've already taken 4,228. We said that there's a total of 6,404 from Dr. Unger's paper, the survey of 34 different hair transplant surgeons. And so this minus this gives us the number of follicular units remaining after that initial FUT procedure. And then we said that 41.3% is our excision density that we can take by FUE whilst maintaining a nice appearance to the safe donor area. 41% of 2,175 is around 900 follicular units. Now consider a second scenario in which the same hypothetical patient, 30-year-old male with type 5 male pattern baldness, he undergoes FUE only. So he doesn't undergo FUT at all. Doesn't undergo FUT and then later FUE, just FUE. He starts off with the same number of follicular units, those safe follicular units that we got from Dr. Unger's paper. We've got the same excision density by FUE, 41.3, and this time we can get 2,644 follicular units from FUE alone. We can compare those two scenarios, FUT and later FUE versus FUE alone. With FUT and later FUE we got about 5,268 grafts. We got 2,644 from FUE alone. Look how many more grafts we can get from FUT and later FUE. Over 2,600 grafts. That's 2,600 with FUT then FUE over FUE alone. That's a 40%, over 40% increase in the number of grafts we can get from FUT over FUE. And this is just to highlight it. What conclusions can we make from that? Well, in terms of lifetime number of grafts, FUT then FUE completely trumps FUE alone. You can get over 2,600 more grafts. This is officially a mega session. A Norwood 3 patient could probably have his hairline completely restored with 2,600 grafts. It is an entire surgery. 2,600 grafts could completely restore the frontal half of someone's scalp. It is a significant procedure and possibly life-changing for some patients. So really the take-home message is this. FUT should be used as the primary procedure, meaning the first procedure. That allows you to get that juicy, androgen-resistant area. That allows you to get all the grafts from that area. 100% of them. Now we have assumed 100%, they're likely not quite 100%, but close to it. Second thing is that FUE should only be used as a supplementary procedure, supplementary to FUT. And the reason for that is because if you do FUE first, you completely decimate the safe donor area. You can only take 41.3%, in the average patient that is, you can only take 41.3% of grafts, and if the average patient has 6,404, that only leaves you with 2,600 grafts that you can safely take. Those are permanent grafts that you can safely take, granted, but you've decimated the safe donor area. That means that if you do FUT in the future, you can only take much fewer grafts, and you're not going to get all of those nice, rich, androgen-resistant grafts in the center of the parieto-occipital region there. Those juicy grafts that FUT takes all of. If you've got this far, thank you so much for listening and watching. I think the results were quite surprising for both me and Dr. Bloxham, and it goes to show that FUT does still have a role in hair transplant surgery, specifically with maximizing the number of grafts over a lifetime, which I believe patients deserve to know, especially those who are more predisposed to advanced hair loss, particularly patients that are experiencing significant hair loss at a young age. That's usually a bad prognostic factor, as well as those with who are already Norwood 6 or Norwood 7. These patients deserve to have the greatest number of grafts over a lifetime. The other thing to remember is that a lot of clinics will claim that they can harvest a lot more follicular units than we've stated in this paper. They're only going to be able to do that if they go outside the safe donor area or in patients who are genetically blessed with very high starting follicular unit densities in their safe donor area. It's also important to remember that different hair characteristics affect the end cosmetic outcome and should be taken into account when deciding which approach to take. Outside of my paper, I do have some additional points I want to emphasize. The goal should be the correct approach for patients, and that is very, very important because it's completely subjective. No one needs to have hair transplant surgery. The goal should be up to the patient, but they deserve to know all the information, and knowing how many lifetime grafts that they can get, in my opinion and in Dr. Bloxham's opinion, is very much part of what they should know. Another point to remember is the graft to surface area ratio. Density depends on how many grafts there are in a given area of the scalp. If you have lots of grafts in a small area, then you'll have high density. If you have very few grafts in a large area, you'll have low density. And the benefit of FUT is that it takes the grafts, but it also takes the section, it takes a large surface area of the scalp with it. And so it doesn't increase the surface area or decrease the number of grafts, so it doesn't actually decrease the density of the safe donor area like FUE does. And the final thing to remember is that FUT removes close to 100% of the most androgen-resistant grafts. You only have to look at a lot of patients to see that the safe donor area is really not as large as people think. There is retrograde alopecia upwards and anterograde alopecia downwards. The safe donor area in some patients is literally confined to this single strip here. An FUT guarantees you take all of those most androgen-resistant grafts. This cannot be overlooked. The final 2 points are from anecdotal experience, from my experience in seeing a lot of Dr. Bloxham's cases, is that graft survival is better in FUT than it is in FUE. And whilst we haven't included or accounted for graft survival in the paper, anecdotally we have seen better outcomes and better graft survival with FUT over FUE. And the FUE procedure results in greater handling of the grafts themselves, which causes damage. The final point is the transection rate. As mentioned, we did not account for the transection rate, but transection rate is likely much higher in FUE than it is in FUT, especially in patients who are of Afro-Caribbean descent, who have curly hair. It's very difficult to make the punch and to include the whole length of the graft and the bulb itself. Often the FUE procedure transects the bulb of the grafts. With FUT that is not the case. There is very minimal transection with FUT. We take the whole strip, we keep the grafts within the tissue, and that keeps them healthier for longer and does result in better cosmetic outcomes.